One of the things that really works for me is I love talking about this. So that helps a little when you have good energy about what you're speaking about. I want to thank you, Irma, for the invitation to be here, Rick, and Denise as well, and all of my colleagues from Yale. I have learned so much today. This is like super exciting for me. And I want to acknowledge colleagues from another project that Dr. Altice and I are doing. Our collaborators from Kazakhstan, Tajikistan, and Kyrgyzstan are here. And that's also really exciting for us. So what I'm going to talk about is something that we will have more chances to talk about in the next couple of days. Tomorrow we'll have a conversation about coaching and facilitation. I think you're also going to hear a talk from Rick about that topic. We will on Friday have the opportunity to practice one of these tools together, as well as I will have the opportunity to do a workshop in the afternoon on Friday. So I'm going to run through some things really quickly, but I want to draw your attention to that this is called NIATx. It's Unpacking the Implementation Tools, a comprehensive implementation strategy. This differs very much from an implementation framework, right? This is a strategy for doing actual implementation that can be used with multiple implementation frameworks, and we have used it with multiple implementation frameworks. So don't want to confuse that. These are very practical methods that are designed for real-world implementation, which is one of the kind of tracks of this program here. So NIATx originally stood for an English acronym that says Network for the Improvement of Addiction Treatment. That turned into NIATx, which isn't even a word, right? So NIATx was originally a grant program from the United States federal government, the Substance Abuse and Mental Health Services Administration, and as well as the Robert Wood Johnson Foundation, was a private philanthropic organization in the United States. This was a very big deal at the time to bring together government money and private money to really work on addiction treatment, right? And the ideas behind this, you've heard many of them today, but the NIATx has been deployed extensively across the United States in many areas of healthcare and other kinds of social service programs, and recently very much so in the carceral system, including by Dr. Altice's teams. International deployment has included extensive work in Ukraine, where we're really still struggling with not being able to go there after being on the ground in Ukraine. Rick for about 20 years and me for 10. We have a lot of excellent colleagues there, but it really hurts not to be able to be with them in person. We have recently, in the last couple of years, been working in the region, first in Kyrgyzstan. Now we've been joined, that project has been joined by colleagues in Kazakhstan, Tajikistan. We have newly developing work in Peru. David is here, our project coordinators, Moldova, and potentially in Georgia. We're hoping that this really works out. So as I said, we've been working across the United States. I have been working with NIATx since 2003 when it was actually founded. I was the recipient of a Robert Wood Johnson Foundation grant, one of 10 granted across the United States, and I literally have never looked back. This is completely an approach that transformed the way that I do my work, the way that I think about my work, the way that I think about the work that you all do, and the people that we care for, regardless of the type of care that we're delivering. So it's a transformative approach from my perspective. You know, at the time, I mean, how many of you have had this experience? You're sitting in a meeting, you have your notes with you, whether they're on your telephone or a notebook or whatever, and some of them are like 2 years old or 3 years old. And you're like still having the same conversation. And people in the room are, they want to be there. That's why they're coming to the meeting. They're interested in whatever the issue or the problem is, but they haven't really moved beyond the issue that is stated, except for their own goodwill, into some kind of change. And that's what the NIATx implementation set of strategies is really about, is moving beyond the problem into some kinds of practical solutions. So we've been in many areas of healthcare, as I said, recently in carceral settings. We're involved in the evaluation phase of a giant criminal justice study in the United States, in which 55 jails in the country were recruited regarding efforts to increase medications for opioid use disorder, which have not been typically given to people who are incarcerated, as well as Rick and I, along with Dr. Judith Feinberg, are co-PIs in a grant in West Virginia that's organized around scaling up and integrating care in primary care for opioid use disorder, HIV, and viral hepatitis simultaneously across 20 primary care settings. So there's a number of ways to use this. We are still being funded, and there are many iterations of NIATx. You're going to hear from me and from Rick and other members of our team. But essentially, there are lots of ways of using these tools. Our international deployment, as I said, includes extensive work in Ukraine. We use this in Ukraine as a framework for scaling up medicines for opioid use disorder beginning in 2014. This was a novel way to use the NIATx tools. We've had excellent outcomes and results. This is a NIDA-funded grant as well. We have, and our new R01 is essentially for the same purpose as well. And NIATx is now an evidence-based practice. The seminal article that emerged from the demonstration pilot, in which I was originally funded, along with some colleagues from across the US, was authored by Dennis McCarty. He's at Oregon Health Sciences University. And it described the impact of the NIATx model on access and retention in addiction treatment settings. So this was important because the data on access and retention in addiction treatment settings hadn't changed in 2 decades in the United States. So 75 to 85% of the people who need treatment for a drug use disorder don't enter treatment in any given year, absolutely do not enter treatment. And of those who enter, half of them don't complete treatment. And this has been going on and on for decades across the United States. We have excellent baseline data that shows we are failing to make the impact that we would like to make. So that's where the idea of NIATx came from. What was the compelling reason for trying to change? The compelling reason was we aren't doing as well as we would like to do. And essentially, that is one way of looking at implementation science. Right? What are you trying to do? You're trying to do something better than it's being done now, right? Almost always either trying to develop the evidence, as we've heard about today, and or disseminate the evidence in a wider way. So the NIATx tools can help you do both of those things, but essentially they're organized around understanding what your baseline information actually is and creating a goal of what you actually want to change, right? So that's the basic simple equation. Since that time, we've had more than 60 peer-reviewed publications that support the effectiveness of the NIATx model. So we don't need to prove effectiveness anymore. Many of those are in international settings, again, primarily out of Rick's lab and our collaboration, and many of them are in domestic settings across the United States. So you saw this morning with Luke's talk, you know, the no-do gap. This is a 17-year trajectory here, yesterday, today, and tomorrow. That sounds like 3 days, but it's 17 years long, right? 17 years is a really long time. In many cultures, that's a generation of people, right? That's an entire generation of people. And so the knowledge do gap is the rationale, if you will, again, for trying to use NIATx tools or this bundle of implementation strategies to try to shorten that gap. That's what's really going on here, right? So what we know and using what we know today to inform what we do now so that tomorrow looks different than today does, right? So that's basically what we're trying to do here. And this is a systems thinking orientation. You heard a couple people, I think it was Luke again, and certainly Mona talk about Dr. Don Berwick, right? Dr. Berwick was really influenced by the work of W. Edwards Deming. Dr. Deming is an engineer. He's not a physician. This man is a process engineer. And he says this, when you think about systems, everyone is acting as they should, given the system that they're in. We're all doing the best we can. That includes our patients. That includes practitioners. Everyone is doing the best that they can. You have to assume these good intentions, right? In order to do this work without being upset or sad. There's no bad data. It just is what it is, right? Everyone is acting as they should, given the system that they're in. Your current system is perfectly designed to produce the results it is currently producing. If 75% of the people don't receive the care that we think they need, we have to think about what we can do differently, right? What can we do differently so that gap changes, right? That's an implementation gap. You'd like 100% of people to receive the care that they need. How can we move that from 25% receiving care to maybe 40%, right? What do we do? So what do? We all contribute to the system. This is another fundamental assumption. We all contribute to the system that we are part of, both positively and negatively. So we bring ourselves through the door every day, and so do our patients and our colleagues, right? We bring ourselves through the door every day. So what happened when we started talking about NIATx? So this is architected by Dr. David Gustafson, who's a friend and mentor. He was my coach when I received a Robert Wood Johnson Foundation award back in 2003. He was a colleague of Dr. Don Berwick's and a co-founder of the Institute for Healthcare Improvement. And they were both highly influenced by Dr. Deming. So what did Dr. Gustafson and his team do? They teamed up social psychology and engineers, right, to attack a medical clinical problem. They pulled together, they looked at the baseline data, they pulled together a group of social psychologists and engineers, and they attempting to mediate clinical and organizational processes. They were just trying to short circuit this gap. What can we do, right? What can we really do here? And one of the things that they rely on as we deployed NIATx tools is the collaboratives of essential learning collaborative components. So this comes right out of IHI, again, back to Dr. Berwick, 2003. So all of these things are converging simultaneously. IHI is coming up with this learning collaborative model, right? The NIATx folks are over here thinking about how can we work with regular people who are not researchers and scientists on a day-to-day basis, but rather clinicians and workers, and help them contribute to shortening that knowledge gap that we have, right? So what you have in an essential learning collaborative model is the expert panel up here at the top. You develop collaborative goals and frameworks. This is where you might look at national data, for example. You might bring together like the Ministry of Justice, if you're trying to think about healthcare in a carceral setting, along with, people working in the Ministry of Health, and talk about how you might bridge that gap. So you pull together a leadership group that agree on a particular aim, and that's all pre-work. And then you decide which organizations, in this particular case, which organizations will you be working with? So some of you have had this experience, right? We select various organizations across a particular country or a region and bring them together into what we call a learning collaborative, right? So there's some agreement when people come together that they're going to be working in a particular direction together. This can be screening for childhood obesity, right? It can be using mHealth to figure out when you need to see a physician. It can be, you can have any goal, but the collaborative itself needs to have an agreement that this is the direction that they want to try to move in. So we bring together people in learning sessions, and then you can see underneath there that we teach them using coaching to do plan, do, study, act cycles. Right? We teach them to understand their own local data What's going on in your organization relative to screening for childhood obesity? What's going on in your organization relative to moving people with resistant tuberculosis onto a new medication, right? What is your data? So you work from the 30,000 feet, you look at some national data or regional data, then you move down to your own organization with external coaching, and we bring you together to do these learning sessions that are interspersed PDSA cycles, right? So then we support those learning collaboratives with conference calls, collaborations, monthly meetings. We have some coaches here in the room and external coaching, right? So we pull together a learning collaborative. We work together on a month-by-month basis. We bring the group together about every 6 months to have a look at each other's work. This is all predicated on basic ideas about adult learning. So this is the other thing. Adult learning is primarily not didactic, but we employ a lot of didactics in our teaching, right? Including in clinical medical education. We employ a lot of didactics. Adult learning is primarily predicated on hearing about something, watching someone else do it, and then doing it yourself, right? It's experiential. So one of the beauties of the NIATx approach is that everyone is part of the solution. It's an experiential model predicated on adult learning that's focused on evidence-based practices, right? And so why a process model? So when we were looking at the previous slide, we're doing these plan, do, study, act cycles. They're focused primarily on process. You know, why a process model? Well, customers are served by processes. And it's important to keep in mind that customers are the people that come into healthcare organizations. So when we think about terminology and language, right, these are some of the words I think that sometimes keep us from, we call them patients or residents or inmates if they're incarcerated, right? These are not people words, right? They're persons being served in some particular way. So people are served by processes. That includes a parent trying to take a child to a pediatric appointment, right? That includes somebody trying to enter substance use treatment. That includes a person's mom who's really worried about their adult child, right? These are all potential customers of the process. On the flip side of that, clinicians are also customers. These are the people who come to work every day, right? They're doing the best they can in the system that they're currently in, right? And sometimes we have to assume those good intentions. It's sometimes really difficult to ask the person who's in the system what the system is actually like, right? And the way I talk about this sometimes is, what would happen if we asked a fish to describe water, right? I mean, when you sit down with a bunch of parents and ask them what it's like to get their child into an appointment, they're coming at that from a particular perspective. When you sit down with a bunch of physicians and say, what's it really like to work here? Or why don't you prescribe medicines for opioid use disorder? They're coming at it from a particular point of view. So it's a really important framework, right? To think about all of the constituencies as customers, and you as the person using this set of implementation tools, trying to get a perspective, as Ashley was just talking about, a perspective from various aspects of the community being served, right? They're equally important. Yes, if we were drawing things right now, we'd be drawing a circle. So customers are served by processes, by and large. Processes are not the same thing as bad people. Often when systems don't work, we say, oh, the people who work there don't care, or they're not very nice, or, right? Customers are actually served by process. Those persons are customers too. 85% of customer-related problems are caused by organizational process. So if you call somewhere and nobody answers the phone, and you get a voicemail and you leave a message and no one calls you back, that's a process. That also causes frustration for you, the potential customer, right? So to better serve customers, organizations must improve processes. The model assumes good intentions. Everyone's doing what they can do. Everyone has a backstory. We all brought ourselves to work today, right? It assumes good intentions. This is where the social psychologists really come in here. You know, you take the heat off. People are doing well or not well. We're just doing. We're doing the best that we can, and we're trying to make it work. So in the NIATx framework, what actually happened, what we did was we boiled down this idea of closing the implementation gap to 4 main aims, right? And we think that this applies to almost everything that we've looked at, right? And that is reducing waiting time, no matter what part of that customer continuum you're in, reducing no-shows. I was talking to Jen earlier, just such a lost opportunity for the organization, for the person being cared for the community, increasing continuation. If you have to take the medicine for 12 weeks to get better, we really want you to make it through that 12 weeks, right? And increasing the number of admissions, because we know that there's such a big gap in between need and actual implementation. So there's a couple of pieces of real science that come here. There's a lot under the hood, but the NIATx founders, we really tried to make this super simple, right? So one of the things that's important to keep in mind, there are evidence-based predictors of change. This comes from a factor analysis authored by Dr. Gustafson, as well as Lynn Mahara from the British National Health Service. And this is a factor analysis that looks across the literature that predicts successful change. They came up with 5 evidence-based predictors of change. Understand and involve the customer. Number 1. If you want to know why people don't show up to their appointments, you have to ask them. Can't assume it's because they don't care, right? If we want to figure something out, we have to actually ask people. You have to focus on key problems. A key problem in the world of treatment for opioid use disorder is that most of the people who need medicines for opioid use disorder is far and away the most evidence-based approach for the treatment of opioid use disorder. Most of the people who need these medicines are not on them. That's the gap. That's the key problem. Now, there may be a lot of other problems, but you have to keep your eye on the prize, if you will, right? How do you scale up, in that case, closing that gap between the number of people who need something and the number of people who actually have it? Right? So we've got to keep our eye on the prize. It's really easy to get into the weeds here and start to nudge around the edges a little bit and not really think about what is the big goal, what's the overarching goal. You have to select a change agent, right? You see some of them here in the room. I'm hoping many more of you will think about doing this yourselves. To seek ideas from outside the field and outside the organization. Now, there are lots of organizations that solve these gaps in really creative ways. Right. So one of my favorite examples is that there's a restaurant in the United States. I think it's going to close soon. I heard that. It's called Red Lobster. Right. Yeah, there's a restaurant in the United States. I used to take my children, who are now grown. I used to take my children there because they loved it. And it was always so busy, this restaurant. I was like, oh, you guys, really? You want to go there? So we would go to the Red Lobster and you'd walk in and the woman or person at the host stand would hand you she would say, look, it's going to be the wait's 25 minutes. But she said, I'm going to give you this timer. And when your time is up, it's going to flash, right? So here's a place you can go sit over there and wait for a little while. Okay, 25 minutes. I'm like, okay, we can deal with that. Well, the thing always starts flashing in 17 minutes. They always beat the goal, right? I mean, it's just brilliant. So now I'm excited. I've waited 17 minutes for something I didn't want to wait for in the first place, but I win because you gave me 8 minutes back, right? I mean, it's just a brilliant strategy to kind of normalize waiting time, right? And to think about it from the person's perspective. Right? So seek ideas from outside the field and outside our own organization. If you have open clinics, how long do people wait? What are they doing while they're waiting? Can you normalize the wait time? Do you tell them before they come in? that maybe, I'd love to see you today. I'm not quite sure how long you're going to wait, but I'm going to see you before 2:00. There are all kinds of strategies for thinking about ways to kind of make experiences that are potentially less than pleasant if people don't have an expectation, right? So this plays into this set of ideas about clarity of expectation that we heard about earlier today. And then lastly, the 5 principles: do rapid cycle testing. Don't deploy an intervention across 30 sites unless you already know that it works, right? Do rapid cycle testing, do some small tests, make sure you know that it's actually going to work before you do spread of that innovation. Well, interestingly enough, in this factor analysis, the first principle outweighs the other 4 added together. So understand and involve this, not always the result that we get in factor analysis, right? So understanding and involving the customer is critical to successful, predicting change. Another really important thing here, under the hood of the NIATx ideas, remember we talked about adult learning, is the co-production of knowledge. You have to do the whole circle, right? Patients are not to be objectified, right? People who want to eat at your restaurant are not to be objectified. They're customers. So the co-production of knowledge that is developed together between change teams and the coach. And it has to be context-based, which we've heard several times today, has to be pluralistic, right? Everyone has to have a voice somehow, has to be goal-oriented and interactive. And then the 4 elements of working with a co-production approach: equality, diversity, you heard Ashley talk about that a little bit, accessibility, and reciprocity. So it's very important in the coaching or facilitation relationship. This is what the coach is trying to bring to the table as we deploy the NIATx tools, right, that are predicated on ideas about kind of leveling the situation so that one of the actors groups, i.e. clinicians, perhaps in the case of medical interventions, is not more ascendant than others when it comes to trying to think about how to create the solutions. The NIATx toolkit, we'll have a lot of time on Friday to talk about this for those of you who choose that workshop, but we also will do some work on nominal group technique together, as well as coaching and facilitation tomorrow. In the NIATx toolkit, we are clear that the number one thing that must be done is to set an aim. You must know where you're going, right? You have to know what you're trying to change in order to know if a change is an improvement. Change teams have executive sponsors. I think it was Rick who spoke about that this morning, someone who gives permission to the team to actually make changes, a change leader, and someone who looks at day-to-day data, right? This does not have to be a statistician. This is not fancy math. We're kind of counting things, if you will, right? Did you reduce time or not? That kind of yes or no data kind of questions. We use rapid cycle plan, do, study, act approaches. All data is useful. And what we're looking at here is an engineering technique that is known in the field as fail fast. If it's not going to work, figure that out right away. That's okay, right? All data is equal. All ideas are equal, but some things work better than others. So if it doesn't work, say, okay, that didn't work, and move on. Try something else. If you invest 2 years in the solution, it becomes really difficult to move on, right? So you really want to be thinking about what can you test in real time that helps you figure out whether you're moving in the direction that you want to be moving in. So PDSAs, or rapid cycle plan, do, study, act cycles, are guided by the following facilitated tools. And NIATx coaches are trained. We actually have coaching academies, and we debrief with each other all the time. It's a lot of energy that it takes to keep up the external coaching, if you will. But PDSAs are guided by the following facilitated tools. We do a walkthrough. I'll spend just a minute talking about that. The nominal group technique, flow charting. We do simple pre-post measures. You made a change in the way that you answered the telephone. Did more people leave messages or not? Yes or no? Simple pre-post measures. We develop SMART goals. A SMART goal is not a SMART trial, right? A SMART goal is specific, measurable, attainable, relevant, and time-bound. I would like for the phone to be answered by a real person 50% of the time by July 30th, right? I mean, that's a SMART goal, right? Really straightforward SMART goals that teams can wrap their arms around, that are small pieces of the puzzle that we may need to put together to move toward a much larger goal, right? And then we have a project charter. People have agreed to that. So coaching and facilitation, which we're again going to talk about much more tomorrow, happens in 3 phases that are not linear. This is also important. Many organizational processes go in a straight line. Here's the process book, right? Read this and do all of your things in this way, right? And you never hear from it again, unless you have the potential of some kind of dashboard or something in your work. You just don't know if everybody's following the processes. So in the NIATx universe of coaching, we build relationships first and foremost. Who are the people you're working with? What do they care about? What are you trying to achieve? You build capacity, because one day as a coach, you're going to walk away, and you want the organization to be able to sustain changes, and you're building sustainability. Right? So all of these tools can apply to lots of different situations. You know, I come from a large family. I have about 30 first cousins, and I'm in the middle of that pack. We all have children pretty much. There are a lot of us. When we want to do something as a large family, like have a reunion, you know, we have to use like a tool to figure that out, right? And we use some kind of inclusive approach that has some voting at the end of the day, so that most people, everyone feels involved because everyone got to have their input. And then the voting kind of rules at the end of the day, right? People are invested in this solution. So you want to build relationships, build capacity, so that you can walk away as a coach, but the organization, or the family in this case, is retaining a structure that allows it to go on and solve other kinds of problems. So conducting a rapid cycle change exercise, you want to plan the change based on your own data. Plan the change based on your local data, right? If you're already doing something 95% of the time out of 100, you don't need to make a change there, unless it's wrong limb surgery, right? I mean, you essentially, you want to be selecting a data point that needs improvement, right? Then you do the plan. So you work with your team using techniques like nominal group technique, right? You work with your team to figure out what kind of suggestion you might have for making a change, do the plan, study the results, and then you act on the new knowledge, right? So if you're screening for childhood obesity, the first question is, what is your denominator? Is it everybody who comes into clinic between ages 5 and 12? I'm just making this up because I have no idea, right? But is that your denominator? Okay, so you can figure out what that number looks like, right? Are you screening them all? Well, I don't know. And do you? Right? So that might be a starting point. Maybe you don't know if you're screening all of them. Right? So you might dig into that and find out, oh, some practitioners really screen their patients and some don't. Then you might sit together with everyone, present that data, and say, what change could we make so that we move from where we are today to a slightly better outcome, right? So that's planning a change based on your own data. You might have to back up to get the data. That's doing the plan. Maybe you introduce an instrument to your practice. Then you study the results. In 3 or 4 weeks, you should have results. Don't do this for half a year, right? So if you go from 50% of your incoming patients being screened to 70%, you ask yourself, are we moving in the direction we want to be moving in? Yes or no, right? This makes the biostats people insane, right? But you ask yourself, are you moving in the direction you want to be moving in, right? If you are, then you ask yourself, okay, what are we going to do about that? Right? You ask yourself the same question if you're not. Right? All data is equal. Data is all good, right? So you look at the universe of people being screened, you ask yourself, did we move in the direction we want to be moving in? And then you decide what you're going to do next. Are you going to adopt the change? Are you going to adapt it a little bit? Maybe you need a different instrument or a shorter instrument, or only two of the questions really matter, right? Or are you going to abandon it? But you've only put 2 or 3 weeks into this, right? So this is rapid cycle process improvement that's oriented toward the larger goal of understanding that you can prevent obesity in adults, which has a lot of negative health outcomes, if you can identify people early in their lives, right? I mean, so you have this evidence-based idea that's very well established in the literature that you're trying to adopt in practice in real world settings by moving closer and closer to the goal that you actually set, right? And then what happens generally is that we adapt these changes. So we're doing multiple PDSAs over time, and they're small. So we heard that from one of my colleagues earlier today. You know, what you want to be looking at in the field are small changes, one at a time, so you can tell what actually worked, right? What actually worked in terms of moving you in the direction you want to be moving in, but you have to do multiple changes to move toward your goal. So when we do rapid cycle testing, we start by asking ourselves 3 questions. What are we trying to accomplish? You have to keep coming back to this. And it is really so interesting to do that, right? To try to keep refocusing yourself. What's really important here? What are we trying to accomplish? Because it's much easier to get sidetracked sometimes than to take on a problem like, could we get everyone to prescribe medicine for opioid use disorder to people who have opioid use, right? That's a big problem. So it's easy to get distracted by that. What are you trying to accomplish? How will you know if a change is an improvement? Right? How will you know if a change is an improvement? And if you have to wait 3 years, then that's more like a clinical trial, right? I mean, in this case, we're talking about bringing evidence-based practices to practice, right? They're already established as practices that will work for people if we can get them to those practices. And what changes can you test to do that? Right, so conducting a walkthrough, this is one of our key tools. This has some legs in the literature, but it's really NIATx that's advanced this mostly. Play the role of a person trying to get into treatment. Now, have you tried calling an addiction treatment agency and saying, I think my kid has a drug problem? You know, what do they say? Or call and say, I'd like to have an HIV test. You know, I'm not sure what if I'm okay, right? I mean, what happens? I mean, this is a way of kind of testing the system, because that is just plain old knowledge. It's not the secret shopper. We have this in the US, secret shopper, right? This is not intended to be secret shopper. This is, so if you're going to do walkthroughs in your organization, or even here, what's it really like to try to register for a course? Is it easy? Is it hard? What's the process? How long does it take? Right? So you have to try and experience the process, or you can be a concerned other, right? There are lots of concerned others in our cultures, and we often leave them out of the equations that we create for pulling people into practice and care. Try to think and feel as those persons would. Think about what you might want changed. I'm one of these people that I have a real aversion to going somewhere new if I don't know where the bathroom is. I mean, what am I supposed to do when I get there? Right? Is there a sign? Like, you know, I mean, it's just a thing, right? But try to think and feel as that person would if you really want to be welcoming to the customer. Ask the staff what changes they would make. Conversely, you can flip this around. Follow a pediatrician or an infectious disease physician. Follow that person around all day. What's it really like? Right? What's it really like to be you? is a critical question when we're trying to design interventions for organizational change. And then you can compile a list of needs and improvements that can address the problems that you see. This is the kind of data that you roll in to your PDSA, right? So when you're trying to think about what does my baseline data actually look like? What does my baseline data look like? How do I plan? You use that local data that you have, right? Maybe you do a walkthrough, perhaps you conduct a nominal group technique, maybe you do some flow charting, you pull all of this together, and then you decide what you're going to do. So one of the benefits of NIATx is really that it's a way to involve staff, which improves morale all around and move toward creating new opportunities for both the organization and the people who use it. NIATx sees change as a regular and ongoing element of our work. How do you determine what to change? This is a facilitated process that we can learn how to do. How do you find new ideas and generate baseline data? And one important way is found in nominal group technique. So we have something really fun planned for Friday in the morning. Everyone's going to have the opportunity to participate in nominal group technique and to observe it actually happening. Interestingly, nominal group technique was developed by David Gustafson back in 1975. This book, Group Techniques for Program Planning, also includes the Delphi method, which some of you may be familiar with, right? So these folks have been thinking about this for a long time. Like, how do you really get feedback from people? And this set of ideas is predicated on getting that feedback and then putting it into action, right? Put it into action in real time. So in the NIATx universe, we talk about breakthrough innovations. Aim setting is a breakthrough innovation. There are many organizations, committed and concerned groups that don't exactly know where they're going. They don't know what it would look like to accomplish their goals, right? And that means you can't measure your progress toward the goal, right? Aim setting is a critical and fundamental idea to the NIATx approach. Rapid cycle change, in other words, being able to do something in a couple of weeks or a month, that appeals to both logic, because we're trying to change something that we know has the potential of helping people, but it also appeals emotionally. It's really nice to see results in real time, right? That feels really good. This is where the social psychologists come in and kind of join forces with the engineers again, right? That you're appealing to people's knowledge base, but you're also appealing to their emotions. Or you could think about this as sort of like type 1 and type 2 thinking, that you're doing both of these things simultaneously in a rapid cycle process. The walkthrough as an opening experience, you really don't know what it's like to be somebody else. And unless you try in some systematic way to gain that experience, at least to bring forward some objective thoughts that you have about another person's experience, no matter which side of that medical clinical equation they might be sitting on, you really just don't know what that's like until you try to figure it out. And you can figure it out using walkthroughs, using nominal group technique, et cetera. And then the business case or clinical outcome is very important. It's tied to a strategic advantage in real time. And I'm going to show you a couple of examples of that really quickly. The advantage is tied to population level health outcomes and ultimately to the organization or the field. So I have 5 minutes. Starting a change project, select an aim, select the change team, name a change leader, an executive sponsor, and a data person. Conduct a walkthrough. You can do this. I have friends who do this now, like they're checking into an airplane. What's it really like? They don't really love it when you come up to the counter and say, well, you know, you could change these 4 things and that would have made my life much easier. But there really are customer feedback forms that you can use to do that. Collect baseline data like nominal group technique, flow charting, local data, review your data and your walkthrough, and then suggest a process change. Right? So a couple of quick case examples. This is one of my favorite. This is from Rhode Island, which is a small state on the eastern seaboard of the United States, where they have a very high, they had a very high rate of death from drug overdose from people getting out of jail and prison. So they decided that they wanted to reduce the rate of drug overdose. That's the aim. We want to have fewer people dying of drug overdoses. Big picture. So what did they do? The first change they made, this doesn't seem like a big deal, but it was to them, continuing everyone who entered incarceration on their existing medicine for opioid use disorder. They were already good at doing this for things like hypertension, right? Or other psychiatric conditions. If people were prescribed a medicine, when they were incarcerated, you kept them on the medicine. But we didn't do that anywhere in the US for people who had opioid use disorder. So they made this one change. Okay, we can handle that, right? What was their second change? They decided to screen everyone who came in to incarceration for opioid use disorder. And they started doing that with a single item screening questionnaire. This is from Wakeman and Company, now endorsed by Substance Abuse and Mental Health Services Administration, right? Screening everyone. You don't know what the denominator is until you figure it out, right? After they figured out the denominator, they decided that people who screened positive and were diagnosed with an opioid use disorder would be offered a medicine for opioid use disorder. Now, you can't make people take it, but you're offering this medicine for opioid use disorder. And then they did active discharge planning so that they could introduce people who were getting out of incarceration to continuing care in the community. In 1 year, this is Tracy Green, this is her study, reduced post-incarceration overdose death in Rhode Island by 63% in 1 year. Right, really straightforward. All they did was apply evidence-based practices. We already know the medicine works. We know some people are on it. We don't know how many people are positive for opioid use, but we can find out, and then we can offer them a medication. This is a very excellent example of just keeping your eye on the aim, right? And of course, I'm making these things sound simple. There's political will involved in all of this. There are practitioners that you have to help get used to this idea, right? But these are the actual discrete changes that they made. And I can stop with that just so we have time for questions. Is that good? Good.
Thank you so much. Thank you so much. I think that day after tomorrow, you will help the participants to be equipped with those tools that you mentioned in your excellent lecture. So I know that, well, we all are full of information. We're processing like crazy, but well, perhaps you have some questions. We have a few minutes for questions.
That's absolutely fine. So when we're looking at, because I'm not sure anyone's tireder than I am, we're looking at performance management metrics. The framework here is really to think about services that people can and will come to, that we can actually pay for, and that work. There's a whole set of references attached to this slide deck that you'll have the opportunity to have a look at. And I am around for the whole week. And I'm excited about that. So thank you.
Thank you so much.